Xin chào tất cả các bạn. Thì hôm nay chúng ta sẽ cùng tìm hiểu về một cái CME với tựa đề là tối ưu hóa kết quả suy tim trong cái đại dịch Covid-19. Và bài hôm nay sẽ được trình bày bởi bác sĩ Muthu Varugathan. Ông là một bác sĩ chuyên điều trị về tim mạch ở Bệnh viện Phụ nữ và Brigham thuộc trường Đại học Y khoa Harvard ở Boston, Massachusetts. Ok, chúng ta cùng bắt đầu nhé.
Hello, my name is Muthu Vaduganathan. I'm an attending cardiologist at Brigham and Women's Hospital and Harvard Medical School in Boston, Massachusetts. Welcome to this program titled Optimizing Heart Failure Outcomes During the COVID-19 Pandemic. Over the next 15 minutes, I hope to take you through the striking impact of COVID-19 on heart failure care, both in the United States and worldwide, and discuss strategies to improve health outcomes of this vulnerable, high-risk population. COVID-19 has a myriad of direct effects on the cardiovascular system that have been recognized over the last year of the pandemic, including in promoting venous and arterial thrombosis, myocardial injury, cardiomyopathy, and inducing ventricular and atrial arrhythmias. There have been mixed and varied reports regarding risks of myocarditis with COVID-19. This appears largely to be related to myocardial dysfunction as a function of a large circulating inflammatory milieu, and less so related to direct viral infiltration of the myocardium. Regardless, patients with heart failure face important risks when faced with COVID-19. In a recent large-scale study of the premier healthcare database led out of Brigham and Women's Hospital of over 130,000 patients with heart failure, a quarter unfortunately died during hospitalization for COVID-19, and these hospitalizations were associated with striking increases in healthcare utilization. And that was even compared with hospitalizations for acute heart failure or other reasons. In addition to these direct health implications, COVID-19 has had impressive and important indirect impacts in causing delayed or deferred care. In fact, across our own health system, Mass General Brigham, we witnessed about a 40 to 50% reduction in all acute cardiovascular care presentations, namely hospitalizations for myocardial infarction, stroke, and heart failure. In the first month of the pandemic in Massachusetts, these same observations have been mirrored nationwide and globally and have crossed many medical disciplines, and including for heart failure. In addition to deficits in inpatient care, we've seen important restructuring in ambulatory care practices for chronic medical conditions, including heart failure. In the United States, at the peak of the pandemic, we saw about a 60% deficit in ambulatory care. This has slowly rebounded in recent months. In addition, we've seen challenges with respect to access to prescription therapies during the pandemic. We surveyed a large number of pharmacies, about 60,000 pharmacies across 50 states, reflecting almost 17 million claims, and took a look at 10 important classes of therapies and identified slow reductions in prescription fills as the pandemic progressed for important cardiometabolic therapies such as losartan and lisinopril. Unfortunately, these varied indirect and direct effects may have had important health implications for this vulnerable group of patients. Recent data from the National Center of Health Statistics showed higher cardiovascular deaths observed during the COVID-19 pandemic compared with the immediately preceding period of time. Important increases in mortality were seen, especially for ischemic heart disease and hypertension. So what can we do to combat these large and important effects that COVID-19 has had on heart failure care? Thankfully, 2020 and 2021 have been years of impressive discovery and care innovation amidst the pandemic. CMS has announced large-scale waivers in which virtual care has rapidly expanded to fill gaps in ambulatory care. And in fact, across most health systems, we're now back at prior volumes of care. We're seeing the same numbers of patients. In addition, the FDA continues to be active in approving new therapies for heart failure care, allowing for new availability, and care guidelines and expert consensus pathways continue to become available to inform the public about best practices. When discussing heart failure care in 2020 and 2021, it's important to consider that we've had important progress in the development of effective medical therapies to prevent mortality, prevent hospitalizations, and improve health-related quality of life. Over the last 35 years, we've learned a tremendous amount about optimal care practices for patients living with heart failure with reduced ejection fraction. 4 foundational therapies, sacubitril valsartan, the beta blockers, the mineralocorticoid receptor antagonist, and the sodium glucose cotransporter 2 inhibitors, have been identified to extend survival, prevent hospitalization, and improve health-related quality of life. These 4 core foundational therapies target 5 mechanistic pathways: angiotensin II, neprilysin, the sympathetic nervous system, the mineralocorticoid receptor, and the SGLT2 receptor in the nephron, and may afford important improvement in overall survival and hospitalization gains. However, no single trial has actually assessed how these therapies could actually be effectively combined. Earlier this year in The Lancet, we attempted to understand, if combined, what would be the anticipated health impact in patients with heart failure. Combining data from 3 large-scale randomized clinical trials, Emphasis Heart Failure, which evaluated the MRAs, Paradigm Heart Failure, which assessed sacubitril valsartan, and DAPA Heart Failure, which assessed the SGLT2 inhibitor dapagliflozin, we estimated the potential survival gains if all 4 of these therapies were combined, compared with a cohort who had more limited therapy with just ACE inhibitors and ARBs and beta blockers alone. We found that while many patient cohorts and across a broad range of ages, young patients especially, stand to benefit, especially from combination therapy. We estimate that a 55-year-old living with heart failure with reduced ejection fraction may expect up to 6 years of extension in survival with combination therapy with 4 drugs, compared with more limited therapy with 2 drugs, with an ACE inhibitor or ARB and a beta blocker. Over the last year, during the pandemic, we've learned how to best practically combine these foundational compounds. These therapies thankfully have no important drug-drug interactions. They have largely non-overlapping target mechanisms of action. They have limited interactions with respect to important side effects or adverse effects, and can be safely initiated over a short duration of time, even after a hospitalization for decompensated heart failure. We've also understood that these therapies have rapid improvements with respect to health status, LV remodeling, prevention and recurrent hospitalizations, and even reductions in mortality that can occur as early as weeks after initiation. We've also learned a tremendous amount of other therapies that have important benefits in preventing hospitalizations and keeping patients alive in the ambulatory setting. For instance, a recent clinical trial called Victoria evaluated a new compound that also augmented cGMP signaling that may afford favorable myocardial effects. This compound, called vericiguat, was shown to reduce cardiovascular mortality or first hospitalization for heart failure in a very high-risk cohort of patients who had a recent worsening heart failure. Vericiguat has now been approved for use in patients with chronic heart failure and reduced ejection fraction below 45%, and may be an important adjunct in this high-risk group of patients who have suffered from worsening heart failure. Similarly, we learned over the last 5 years that ivabradine, a funny channel inhibitor, was shown in the SHIFT trial to prevent hospitalizations for heart failure amongst patients who were already maximally treated with beta blockers but still had residually elevated heart rates in sinus rhythm. This, again, is an important therapy for a select group of patients to prevent hospitalizations. We also know that isosorbide dinitrate and hydralazine have important benefits, including in reducing mortality in self-identified Black patients with heart failure in the United States. This was shown in the AHEFT trial and may be an additional component for this selected group of patients who face special disparities in care during the COVID-19 pandemic. Taken together, the arsenal available for use for heart failure with reduced ejection fraction has rapidly expanded. There are 4 core foundational components of care that extend survival, prevent hospitalizations, and improve health-related quality of life in a broad group of patients. Then we have selected therapies that can be targeted individually to high-risk subsets of populations that may need additional care beyond the foundational core regimens. These have now been integrated and updated in easy-to-digest documents, such as the 2021 expert consensus pathway put forth by the ACC that answers 10 pivotal issues that may commonly come up in clinical practice by patients and physicians in the care of heart failure with reduced ejection fraction. All this is to promote best available evidence to allow for patients to start and stay on therapies that can keep them alive out of the hospital and feeling well. We have multiple tools in our arsenal now available to prevent hospitalization, which is an important time point in a patient with heart failure's life journey that may be an inflection point in risk. In addition, we've had better information and higher quality information to inform practical issues in the care of heart failure during the pandemic. Initially, there were some concerns about the use of ACE inhibitors and ARBs in this high-risk population of patients either exposed or with COVID-19 because of the interaction of ACE inhibitors and ARBs with ACE2, the binding site for the SARS-CoV-2 virus. However, now we have at least 2 large randomized clinical trials that have provided reassurance that continuation of ACE inhibitors and ARBs in at-risk patients is safe. The largest of these studies, Brace Corona, recently published in JAMA, of about 700 patients across 29 hospitals in Brazil, were randomized to either discontinuation or continuation of ACE ARBs over a 30-day period, and showed comparable numbers of days alive and out of the hospital. These data have supported current broad multi-specialty consensus clinical practice suggestions and guidelines that patients who are on ACE inhibitors and ARBs should continue treatment unless otherwise advised by their physician. In addition, while public vaccination for COVID-19 is still underway and prioritization pathways are being developed, including by organizations like the American College of Cardiology, it's clear from the available data that patients with heart failure represent an especially at-risk cohort. And much like other vaccinations, such as influenza vaccination, COVID-19 vaccination should be prioritized in this vulnerable population. We've seen many different waves of the COVID-19 pandemic that have affected heart failure patients. The first wave, we saw large, important mortality and morbidity directly associated with the health effects of COVID-19. We've seen high post-discharge acute care utilization, as well as long periods of recovery, especially amongst our patients with chronic medical conditions. The second wave has been seen related to the impact of the care restriction that we saw for non-COVID conditions such as heart failure. And now it's really our duty to address the third wave, which is impacted and interrupted care of chronic medical conditions. We know that heart failure is a progressive disease process and importantly requires stepwise optimization in medical care. And this third wave is really our challenge is to re-engage patients, to provide them with up-to-date best practice information and to find ways to optimize their medical care in virtual care environments. So to conclude, the COVID-19 pandemic has significantly disrupted traditional pathways of acute cardiovascular care and may be associated with higher population-level cardiovascular deaths. Multiple cross-disciplinary societies all recommend continuation of overall heart failure care therapies, including ACE inhibitors and ARBs, is safe, including amongst those patients who contract COVID-19. And these therapies should be continued unless otherwise advised by their physicians. Foundational therapies in 2021, including sacubitril/valsartan, mineralocorticoid receptor antagonists, beta blockers, and the SGLT2 inhibitors, all form foundational therapies to importantly decrease mortality, prevent hospitalizations, and improve health-related quality of life. And optimizing medical care and prioritizing vaccination of vulnerable patients with heart failure, including via alternative virtual care pathways, is especially important during the pandemic. I thank you for participating in this activity. Please continue on to answer questions that follow and complete the evaluation. I thank you very much for your time.
Vâng, bài học đến đây đã kết thúc. Các bạn nhớ làm bài tập để có thể nhận được giấy chứng chỉ CME nhé. Cảm ơn các bạn đã theo dõi. Xin chào và hẹn gặp lại.